Great. Well, thank you all very much for the honor of inviting Dr. Blumenfeld and myself to speak at this MCCPOP annual conference. We're particularly honored to speak on the 40th anniversary of the MCCPOP annual conference, which is fantastic. So I am going to start off with a brief overview of fetal centers in a general sense, but also speak about our fetal center. And then I really want to get to Dr. Blumenfeld, who will be giving an overview, really exciting overview of advances in fetal treatment. And we have no conflicts of interest to disclose. So what is a fetal center? The initial models of fetal centers were, as you probably know, primarily pediatric surgery-led programs, and those were really focused on fetal surgical conditions. And it was really a period of somewhat recapitulation of neonatal surgeries in the fetal space. During these early days, surgical fetal centers really advanced innovation, and there was extraordinary investigation during this time. The open fetal center, the open fetal surgery cases really led to the evolution of the MOMS trial, and which was open maternal fetal surgery for neural tube defects, as you may know. But this also led to great understanding of the significant maternal and obstetric complications for these open procedures. With increasing central involvement and leadership by MFMs in fetal therapy, fortunately, minimally invasive options have been developed, and Dr. Blumenfeld is going to discuss some of those in more depth with you. But I think it's really important to recognize that actually a very tiny proportion of all these complex fetal diagnoses that we care for in a fetal center are actually even amenable to fetal surgery, whether it be open or minimally invasive. And so that really brings us to the broader issues, which for the vast majority of complex fetal cases, these issues are really focused on utilizing the best tools, the leading edge tools and tests that are available for fetal diagnosis, discussing dilemmas, including ethical dilemmas that may occur in considering management strategies, and also the need for comprehensive counseling and coordination of care for both the mother and the baby, and actually for the NICU period and beyond. And this really brings to light a couple of issues, including these differences of perspectives across subspecialties that may be involved in this kind of fetal center, and the potential for disconnects in counseling. So this has really led to published guidelines and commentary and editorials, both by the AAP and ACOG in joint committee opinions, as well as other publications, that really underscores the fact that a true team for a fetal center is what one really should try to achieve. And this is a concept that brings us to what we believe we're really trying to achieve at the Fetal and Pregnancy Health Program at Stanford, and really the concepts that we tried to evolve when we launched our program. Our fetal center is a multidisciplinary diagnosis, family-centered care, and coordinated treatment center for complex fetal, maternal, and pregnancy complications. This was a growth from an integrated model that already existed within the Johnson Center of connection and really holistic collaboration between MFM and neonatology and perinatal genetics. We really have committed participation in our fetal center from every medical and surgical subspecialty, as well as social workers, administration, and many others. And we consider ourselves kind of a construct for not only outstanding clinical care, but for research, innovation, and training. And I'm just showing you here some of the program key concepts that we'll go through in the next few slides. But I really want to start with this concept of how important centralized coordination of care really is for a fetal center especially. And in our center, we really consider this to be a single portal of entry that starts with the referring obstetrician, sometimes in collaboration with one of our MFMs, which we'll talk about, or one of our other subspecialists, cardiology or surgery. And there is really a one point of entry for that patient and family and for the referring physicians to access all the subspecialty care, all of the diagnostic tools, and all of the potential treatment options for that patient. And it's just kind of cartoon-wise here showing you that there is just one stop that is really honestly best for the family, so they don't need to feel that they're coordinating all of their care and reaching out to these individual groups. And it is also great for the referring physician who knows they just have to contact that one location. They will get further information from that. The hub really and the beating heart of that central portal of entry is our fabulous fetal center coordinators. Stephanie Neves and Ileana Flores are our administrative coordinators. They're really the voice at the other end of the phone if you were to call. Meg Homeyer is our lead perinatal genetic counselor. Karina Telreja is also one of our genetic counselors, and they both also act as central patient care coordinators for our program. And this is not the first or the last time you're going to see the website and the phone number as well. I think, when we talk about communication, we really want to emphasize that these collaborative communications and partnerships are really tailored to the specific needs of the patient and that particular patient and family, as well as the referring physician. So we really develop an individualized, personalized team for that patient and family for that diagnosis. This may include coordination of higher level imaging like fetal MRI. It may include coordination of multiple consultations, but I really want to underscore the fact that our goal in these cases and what we're able to achieve in most cases is to facilitate ongoing care and delivery close to home whenever it's possible. And so in many cases, our consultations are really just providing information for the family and sort of setting up for the post-delivery care and outpatient care. I also want to emphasize that we now are able to do these consultations by telehealth, including multidisciplinary consultations. Some of this is also made very much easier by our Johnson Center network of perinatal diagnostic centers that are across the Bay Area and into the Central Valley. And many of you who are OBs in the audience will know these faces very well as the directors and leaders of these perinatal diagnostic centers. So that is a fantastic other connection between the local referring OB and the fetal center as well. So we really are able to serve the entire Bay Area and Central Coast and Central Valley, but we also receive referrals from across California, across the United States, and also in some cases from other countries. Just to give you an idea of our fetal center primary diagnostic category breakdown, first of all, we've been in existence since about 2009, and we have an ongoing mother-baby IRB approved database so that we are able to tell you that we've had about 5,200 referrals since that time. This is the breakdown of our primary diagnoses, but many of our complex fetal diagnoses have multiple organ systems that are involved. Because we are following many patients, we're now following probably about 100 to 120 cases at any given time. But again, I'll just get back to this point that the majority of these cases in which we are involved in some way will be able to deliver locally. In terms of our partnership with families, again, our fetal center coordinators are an outstanding single point of entry. So these families can always connect with the fetal center and the Coordination for the consultations and for imaging will all happen through that central point. As I said, we are now able to do telehealth consultations consistently. Fetal echo actually can be arranged locally by our Stanford Children's Health fetal cardiology group in many cases, and they've really expanded their capabilities in that way. And again, we try to approach families with joint consultations whenever possible, because we can really provide the full range of information to them in one clear sitting. We also provide a good deal of feedback to the referring provider, both personally, and Dr. Blumenfeld, right before we came on, was speaking with a referring OB just about a case that we just talked about earlier today. And we also provide formal feedback through epic notes and sometimes fax notes to them about the consultations, about what we talked about, and what the plans are for the baby generally after delivery, and oftentimes after delivery at the local hospital. The Fetal Center Neonatology team that I'll talk about a little bit later also provides weekly kind of heads up alerts to our partner community NICUs that are part of our Johnson Center network. But also we reach out to other neonatologists that are in the area if there are specific patients that are going to be delivered in those areas as well. So of course, as you've heard me say a couple of times, our goal is really always to try to provide a framework for ongoing care and delivery locally. But of course, unfortunately, in some situations, delivery is required at a quaternary care center, most usually for the baby's sake, but may also be for the mother's sake, or in some cases for both the mother and the baby. And I'll just say that we are very fortunate at Stanford that we have this physical connection with the Stanford Adult Hospital that allows us to care for really the most complex maternal medical conditions. And these women may also be carrying a fetus with very complex fetal conditions as well. And so this connection really means that we're able to provide quaternary intensive care level care to both mother and baby if needed in the very same place. So if delivery at Stanford is needed, and usually that, again, has to do with the fetus and the baby, our fetal center also provides a substantial amount of support and coordination in helping families prepare for this. And that means that our medical social workers are highly integrated into our fetal center team, and they will work with families directly to help them with this transition. I also just want to say that our social workers are another level of continuity of care for babies and for families, in that they start to follow and connect with these mothers and families from before delivery, during fetal life, and during their obstetrical course, through their entire NICU course, and sometimes beyond. Transportation and housing support is also part of our mission and what we provide. The Ronald McDonald House has been an extraordinary partner for us and has really gone above and beyond in helping our families. We also have some additional antepartum housing options. As I mentioned before, we really try very hard to do serial joint consultations and coordinated consultations, which may start out by telehealth, especially for the highly complex cases. And we, as a fetal center team, have weekly multidisciplinary meetings. Now, we used to all meet in a room like that, but obviously with COVID, we have now transferred to complete Zoom conferencing. This also allows us to invite referring physicians as well to come and join our meetings, especially when we're talking about management or imaging findings of a case that they have referred to us. So I just want to then say just a little bit of information about neonatology. This is our neonatology team fetal, we call ourselves, which is a fairly small group. My colleagues, Dr. Chalk, Davis, Chitkara, and Van Meurs, as well as our fabulous neonatal nurse practitioners, Beth Flew-Hardy, Diana Kobayashi, and Nicole Weigel, all play an enormous role. And I will say for the vast majority of complex cases, really it is the neonate or the baby that is most affected. I think our site is perhaps unique in that neonatology plays an extremely strong role. I think that is shifting on the national front, that neonatology is becoming more and more integrated. But I do think it makes a lot of sense to have neonatology as a central component. As I said, the vast majority of complex fetal anomalies primarily affect the infant. The neonatologist is therefore usually the one that's bringing together this entire picture of early and post-delivery care and outcomes. And the neonatologist really bridges the span from fetal to delivery to neonatal care and follow-up. So to that point, I would say part of our fetal center vision is that this clinical arc for complex fetal patients, mothers, and families really has to fundamentally change toward a continuum of care concept, not toward a moment in time, not toward only intervention, but the whole continuum of care for the family as well. And that really brings to light maybe a provocative statement that maybe the fetal center really should be thought of as a new medical home for families who are expecting complex care needs in the future. We are also really fortunate that our fetal center team works really collaboratively together. We've undertaken multiple multidisciplinary studies, and these are just a few topics that we've investigated. We've also focused on education as well as new therapies, and Dr. Blumenfeld will talk about our leadership along with NAFNET in really developing new treatments and therapies for the fetus. Innovation is also a part of our fetal center, and that includes, as shown here, our virtual fetal reality platform. This is one example of that innovation. This allows for really an extraordinary and very up-close view to truly see and better understand fetal diagnoses and interventions. And I think Dr. Blumenfeld will talk about this a little bit more, but this is both good for families as well as trainees. And if you want to experience that up-close view a little bit, you can actually go to YouTube and just type in Stanford Fetal Therapy VR. And so with that, I'm going to hand it over to Dr. Yair Blumenfeld to continue our discussion.
Thank you, Susan. And thank you again for this wonderful opportunity to present today. So the guiding principles of fetal therapy haven't really changed much, but the anomaly that we are targeting when we're talking about fetal therapy should be severe. Historically, it was potentially life-threatening, but nowadays, many of the anomalies that we treat are actually just associated with significant morbidity. The anomaly should be isolated and certainly not be a part of a more global genetic or other syndrome. There should be sufficient human and or animal data to prove benefit. And the risk to the mother hopefully should be known, or at least hypothesized well based on experience or publications. The mom and the family obviously should be well informed. And if we're going to be undertaking experimental therapies, those should certainly be under IRB approval. And we have many, many protocols for that. We obviously take maternal health extremely carefully, and obviously anything that needs to reach the fetus needs to go through a usually healthy mommy. And so assessing comorbidities, be they medical or surgical, is something that we take very seriously. We assess technical factors on how we reach the fetus, determining whether the gestational age makes sense or is it better to deliver, and of course the risk for preterm birth, as would be the case with any intervention. And so here's an example of a case that we had where we performed transvaginal ultrasound trying to assess the cervix. And as we advanced the vaginal probe, we reached the head and realized that the patient was already 4 to 5 centimeters dilated and clearly was not a candidate for fetal therapy. Many people think that fetal therapy is fetal surgery, and that's certainly not the case. We have many, many medical therapies that we employ for a variety of conditions. And again, the concept of trying to treat a fetus medically through a healthy mommy can pose certain challenges, especially, for example, when we're talking about fetal cardiac disorders or arrhythmias, where we need to administer antiarrhythmic medications to try to target the fetus. And you can imagine trying to administer a cardiac medication to a healthy mommy can pose a challenge. And that's when we employ or utilize the relationship that we have with the Stanford Adult Hospital, as Susan was alluding to. And we actually hospitalize these patients in the adult cardiac unit trying to treat the baby. So it's just one example of this combined care. Of course, when we're talking about fetal surgery, there are two types of surgeries that we use. People think these are mostly definitive therapies, but as you can see, oftentimes the surgeries that we perform are merely temporizing therapies, trying to buy time either to get a more advanced gestational age or as a means of improving fetal health, especially if there's decompensation of fetal status, as is with hydrops, and you can see a couple of disorders there. I want to highlight a few therapies because I think there's been some changes in philosophy related to those conditions that we'll highlight over the next 20 minutes or so. First of all, when it comes to twins, by far the most important message that I can impart on you today is determining core unicity in the first trimester. This is something that all of you guys can do in your clinic. You certainly don't need maternal fetal medicine input. And it's really identifying not just the presence of twins, but what kind of placenta and what kind of amniotic separation is present in those twins. And the earlier ultrasounds are the most precise ultrasound. And this is an example of first trimester monochorionic twins, where we see a simple thin membrane between them. And this is very important to do because monochorionic twins, of course, have different risk profiles than dichorionic twins. While everybody's aware of twin transfusion syndrome, or should be or could be, and we'll talk about that in a second, what we're seeing more often and what we're honed in more often now is something called selective fetal growth restriction. That's when one fetus in a monochorionic pair or a dichorionic pair has fetal growth restriction and the other one's appropriately grown. This is more significant and it could be associated with more severe complications in monochorionic twins, because if we have one of the babies passing away because of fetal growth restriction, and we have a monochorionic twin set where we know there are vascular connections along the placental edge, what will happen in the remaining twin will be severe and acute fetal anemia as blood rushes from the living twin directly into the demised twin, which we see here on the left. And what you can end up with in about 20 to 30% of the time is either demise of the co-twin or severe neurological injury. And clearly that's something that we want to prevent. And so one of the things that we can do when we have significant fetal growth restriction is to perform a targeted selective reduction. And we do that by using more often radiofrequency ablation, where we target the umbilical cord insertion site of the fetal growth restricted or sick twin. And you can see in this paper, which is not from our group, when you have selective fetal growth restriction and you need to perform radiofrequency ablation, you can end up with adverse neurological injury or adverse outcomes, even in those targeted cases, in about 13%. So clearly we would only do this if in fact we thought that the growth restricted twin was quite sick, in order to prevent this 30% risk of neurological injury. So this is something that we're very focused now in all of our prenatal diagnostic centers, where we follow all twins, but especially monochorionic twins, with close ultrasound surveillance, trying to identify fetal growth restriction. Twin transfusion syndrome is obviously the most complex of monochorionic twin complications. And that's when one twin sort of passes blood along the surface of the placenta to the co-twin, and you end up having significant increase in blood in one and decreased blood in the other. And so the twin that receives extra blood needs to compensate for the volume and has increased urine production. And the twin that is the donor twin has blood shunted away from non-vital organs like the kidney and towards the heart and the brain, and obviously has decreasing fluid over time. And that's the first stage that you see there, which is oligohydramnios and polyhydramnios. Eventually the condition can worsen and we get to a point where there is so little fluid that the bladder is not visualized in the donor twin. And eventually you can end up with cardiovascular abnormalities in either twin, or hydrops, or even death. And this is what it looks like on ultrasound. On the left images there, you see the polyhydramnios in the first image. the oligohydramnios in the second image. And this is what the oligohydramnios, or what's called the stuck twin or the saran wrap twin, that you can see via fetoscopy. Untreated significant TTTS can lead to demise in 90% of cases, meaning we have a scenario where in 90% of the cases, we're going to lose both babies, especially when TTTS develops before 24 weeks. The polyhydramnios in the recipient twin can lead to additional complications, including cervical incompetence, PPROM. And so this is a very, very serious condition. In these scenarios, the standard of care nowadays is operative fetoscopy, where we insert a scope and a laser fiber and identify the connections between them along the placental surface in order to block the connections between the twins and to avert a disaster. Obviously, there are complications related to that, and one of them is actually something called TAPS, which you may or may not have heard about, which is twin anemia polycythemia sequence, which can develop after laser or spontaneously. When it develops after laser, what it means is that either the ex-donor or the ex-recipient can actually become a new donor or recipient in terms of the blood flow. And so these are complications related to smaller vessels along the placental surface where there's residual anemia and polycythemia. And in order to prevent this, we perform something called Solomonization along the vascular equator, trying to really make sure that we obliterate not just the major connections that we see, but smaller connections that may be related to TAPS post-laser. So putting all that together, since we're thinking about selective fetal growth restriction, TAPS, and twin-twin, we've developed these processes where we keep a very, very close eye on all monochorionic twins. And we're more than happy to share this paradigm with anybody else. And we've done that with other centers around our region. Fetal lung lesions is an area that we've been interested in a while. There's a variety of different types of lung lesions that you can see there. And we spent a lot of time using ultrasound and MRI to delineate the underlying pathology. And we've done a lot of research in this because depending on what the underlying pathology may be, we can certainly offer certain interventions to try to change the outcome in these neonates. So obviously having a mass in the chest can lead to shifts in the location of the heart, obviously lead to preterm birth, especially if there's polyhydramnios developing, and of course affect the respiratory status of the neonate at delivery. And so in case we have a mass with a large cystic component, we can modify shunts that we sometimes use for the fetal bladder and insert those in the chest, trying to remove the fluid from the chest to allow the lungs to grow and also to prevent the shifting of the fetal heart. And we have two shunts that we use, a Rocket and a Harrison. As you can see, these are invasive shunts and carry certain complications. And sometimes if we think that the baby might not need a shunt, but may need a drainage right before delivery, you can see a large cystic mass over there right next to the heart. And right before a C-section, we just drain the fluid in order to optimize the care of the neonate in the immediate neonatal period. And you can see what it looks like post-drainage right before a delivery. And so what was previously completely shifted heart has now moved to the right place. And that is, the goal of that is to help our neonatology colleagues deal with a neonate at delivery. Fetal renal anomalies, and especially ludo, something that we're really interested in, have done a lot of work over the last 2 years, even during COVID. We know that the kidneys develop early on in gestation, and their importance in terms of amniotic fluid production, though, doesn't take over until around 16 weeks. Aside from cardiac anomalies, renal anomalies are quite common, but we see a fair amount of severe renal complications and anomalies in our center. These have to do with cystic renal disease, significant obstruction at various levels of the GU tract, something called fetal lower urinary tract obstruction, which is an obstruction at the level of the fetal bladder, and of course things related to medications, and renal agenesis, which is something that I'll talk about in a second. When the kidneys don't develop, the issue is, of course, one, the kidney and what's going to happen to the fetal renal status after delivery, but more importantly, if the kidneys don't function well, you end up with a scenario where you have oligo or anhydramnios starting early on in pregnancy. And when you think about the fetal lung development in utero, you can see that significant development happens even before 24 weeks. And so if we have anhydramnios starting before 24 weeks, we're going to severely affect fetal lung development. And most babies who don't make it usually succumb to the disease, not because of renal issues, but because of respiratory insufficiency in the immediate neonatal period. We know there's no way to grow a kidney after delivery. We know that neonatal dialysis is pretty complex and difficult. We can try to get them to renal transplant, but that's going to depend on whether or not the lungs function. And so that's led us to think about, is there anything that we can do in utero to alter this trajectory? So if we think about fetal ludo, which is again an obstruction at the level of the fetal bladder outlet, whether it's a male or a fetus, and obviously you can see that these are first trimester images, not a subtle defect, and you can see a very large bladder and hydronephrosis, excuse me. We know that ludo is a finding, not a diagnosis. There are many etiologies. The most common is posterior urethral valves in males, but not necessarily. And again, when we have these conditions early on in pregnancy, especially with the development of anhydramnios, we start to think about shunting or draining fluid from the bladder into the amniotic cavity, trying to increase the amniotic fluids so that we can help the lungs grow and reduce neonatal morbidity and mortality. And so this is what it looks like in the second trimester. Now there's complete anhydramnios, a very large bladder. You can see the dilated kidneys on the right-hand side. And this is what inserting a shunt looks like. Under ultrasound guidance, the trocar goes in the bladder, the distal end of the shunt gets deployed in the bladder, and then the proximal end is outside. Once the shunt is in, we still see evidence of hydronephrosis and hydroureters, but at least in this cartoon that you see on the right-hand side there, we've bypassed the obstruction and helped, hopefully, the lungs grow over time. Obviously, these are invasive procedures and can be associated with significant maternal or fetal issues, the most important of which has to do with the fact that these shunts can migrate or dislodge, requiring multiple procedures, and we have ongoing endeavors trying to develop new shunts that are aimed at reducing the inherent challenges that we have with existing shunts, and we're spending a fair amount of time on those. People have recently thought about fetal cystoscopy. If the shunts are bad, how about if we enter with a scope and use a laser to obliterate these valves? And the issue is, while you can probably put a scope in the bladder and use laser, oftentimes the laser goes in places that you don't want, and you can end up with disastrous consequences. In this case, it was a fistula from the bladder into the anal area on this baby. And subsequent studies have looked at the angles of the bladder outlet and have identified the fact that the angle is so sharp that if you're able to get a scope in, and if you're thinking about firing a laser, you're probably not going to be targeting it to the area that you're interested in. And so people are coming up with new instruments trying to treat this specific condition, but we're not quite there yet. Bilateral renal agenesis is a condition that we've recently been very heavily involved in. And the reason for that is that in 2014, our colleagues from Johns Hopkins described the first modern case of serial amnio infusions targeting bilateral renal agenesis. And what that means is that since bilateral renal agenesis obviously results in early onset anhydramnios, it's a universally fatal disease. And in this case report, they were able to inject fluid after multiple injections, and the baby survived and actually ended up at Packard and received dialysis and transplant. And really what that ended up doing was it opened the floodgates for many different centers, and not even centers, but OBs trying to replicate these outcomes. And the outcomes were disastrous, so much so that a multidisciplinary meeting was performed at Johns Hopkins, and our nephrologist joined that. And essentially, the conclusion was that serial amnio infusion should not be offered as therapy, but rather as innovative research, and that there needs to be multi-center collaboration in this endeavor. And that's really what launched the RAFT trial, which I'll talk about in a second. But this is kind of what it looks like. You have anhydramnios, and under ultrasound guidance, and needles inserted. Amniotic fluid is injected, and you see that over on the right-hand side. We know that babies swallow amniotic fluid. They do that physiologically, and certainly even in the setting of bilateral renal agenesis, and henceforth the need for multiple procedures. And so what we don't know is, what is the optimal time to start these amnio infusions? How often do you need to perform them? What's the fetal benefit? Obviously, you can imagine that if you need to perform 10 or 12 or 15 such procedures, again, through a otherwise healthy mommy, placenta, and uterus, you're going to potentially end up with certain complications, and which centers should be doing this, if at all. And again, that launched the renal and hydramnios fetal therapy trial, which we're a part of and have been a part of from the get-go. This is a multi-site trial led by Hopkins that we've participated in over the last 2 years. And the primary outcome is to see whether serial amnio infusion helps these lungs grow. There's a bunch of secondary outcomes that you see over there on the right. And essentially, we've wanted and agreed and have been a partner for Johns Hopkins because we feel like we have the entire continuum from prenatal management, prenatal diagnosis, obviously the technical expertise to do this, but more importantly, the neonatal and the pediatric nephrology expertise to optimize the outcomes if indeed babies are born with decreased respiratory morbidity that allows them to undergo then peritoneal dialysis or hemodialysis nowadays on the road to transplant. So a very, very long road that we and others are looking into now. As you can imagine, for a highly investigational trial like this, there's significant inclusion and exclusion criteria. In the interest of time, I'll gloss over these, but you can rest assured that there's a lot of oversight for this trial, both locally and in a data safety monitoring fashion. I think Susan has shown a couple of images on this. We have expertise now to perform what are called exit procedures when we have oral or neck malformations where we know these babies will have significant airway compromise or respiratory compromise. And what we do is we form a multidisciplinary team that all coalesces at the time of delivery. And you can see over here on the left-hand side, this is the mom, she's under general anesthesia. Half the baby is delivered, the other half is still receiving blood supply from the placenta. And in this case, our ENT colleagues can then perform a tracheostomy. And this takes about 15 minutes. And at this time, our anesthesia colleagues and us are making sure that mom is safe. And then an airway is obtained and stabilized. And then the fetus or the neonate now can then go to the NICU for ongoing care. Spina bifida is something that we've, I think, spoken about in other meetings, but I just wanted to highlight this again. This is a relatively rare complication, but something that we see several times a year here. The most common spina bifida that we manage is myelomeningocele, but we see a variety of associated conditions, including myeloschisis. Nowadays, these are, of course, still diagnosed either by AFP or second trimester screening. Here on transvaginal ultrasound, you can see the cervix. And here's a dimple in the lumbosacral area where the spine or the spinal canal didn't develop. And we then use MRI to identify an associated Chiari malformation. This is because if you have a lesion down here in the lower part of the spine, because the brain is connected to the spinal cord, of course, the posterior part of the brain herniates through the base of the skull and you end up with hydrocephalus, which leads to high pressure hydrocephalus and a need for a shunt in the neonate. We know that the issue related to this is something called a two-hit hypothesis. The first being the spina bifida and the second being the fact that these nerve endings are then exposed to the amniotic cavity, and something about the amniotic fluid, which we often think about as a sterile environment, leads to ongoing damage. And that's really what led to the thinking that if you can cover the spinal canal in utero, you can prevent this ongoing trauma to the nerve endings. And so we spent a lot of time trying to identify where the lesion is, because we know that the location of the lesion will then affect ambulation in the absence of in utero therapy. And then we counseled patients about the need for ventricular peritoneal shunt or another diverting procedure postnatally, difficulty with ambulation, bladder, bowel incontinence. So this is an example of a fetal anomaly that is not necessarily associated with mortality, but is associated with significant morbidity. This is what a postnatal repair looks like. This is usually performed the first day or two of life. This is what the lesion looks like afterwards. The first part is dissecting this placode. The nerve endings which are exposed are then go into the base of the spinal cord. And then with multiple layers, the skin, dura, and myofascial layer are oversewn. And when we perform these in utero, the standard of care therapy is via open fetal surgery, where mom is under general anesthesia, the uterus is exposed, an incision is made into the uterine cavity, and then the fetal spine is exposed there. And similar to a postnatal repair, a multi-layer closure is performed under ultrasound guidance by echocardiography. These are our pediatric neurosurgeons closing the defect in multiple layers, and of course, closing the uterus. And this is performed by 26 weeks gestation. Obviously, I showed you 4 pictures really quickly, but there are multiple teams that are involved with this, as you can imagine, with multiple sessions of counseling pre and post. The MOMS trial that Susan alluded to, which really launched open fetal repair for this, was a multi-site trial where patients were randomized to prenatal repair or postnatal repair with very strict inclusion and exclusion criteria. And the bottom line was that prenatal repair decreased the need for shunt placement by 50% and doubled the risk or the incidence of walking independently. So decreased neurological injury and improved walking. And this is really what launched in utero repair around the country, and certainly at Stanford. The problem was that when you open a uterus, repair the fetal defect, close the uterus, and continue the pregnancy, things can go awry. Obviously, you end up with a preterm birth. More often than not, you can have PPROM. The prior surgical site can become quite thin. And then the medications that we give to the moms in order to prevent preterm labor can lead to pulmonary edema and the need for blood transfusion. And that really launched the concept of fetoscopic repair. There are several approaches to this, but the idea is that instead of making a large incision on the uterine wall, you can then insert smaller instruments, remove amniotic fluid, insert CO2 gas in order to optimize imaging, and perform a similar repair that you would via open fetal surgery, but rather do that via fetoscopy. And you can see the repair there, and then insert amniotic fluid and use similar medications to try to get to a more reasonable gestational age. And the initial experience from that has shown that you can actually end up with even more advanced gestational ages. Some of these women actually can deliver vaginally because you did not make a large uterine incision. The port sites appear to be well healed compared to a large incision. And similar to open fetal therapy, there seems to be reversal of hindbrain herniation in not an insignificant amount of cases, and similar results in terms of the fetal benefit, where only 40% of neonates then need a shunt. This is still experimental. It's under an IRB. We offer this to our patients now at Packard, and more information is needed. Susan alluded to the fact that we launched this virtual reality product. The idea is to have patients who encounter these conditions, whether it's TTTS or fetal spina bifida, we can then use virtual reality to highlight what their fetus or fetuses have and what our surgical approach is going to be. Unfortunately, right after we launched or developed this product, COVID hit, but we're very, very excited for the resolution of COVID so that we can now offer this to our patients to better explain what the physiology and proposed therapy are going to be. We're a part of the North American Fetal Therapy Network. Not only are we a part of it, but we're one of the leading centers in that. There are many other trials that we're participating in related to fetal therapy and fetal medicine more globally. And in summary, this is our phone number, Dr. Susan's and my cell phone if you ever need anything. And we're very, very excited and honored to participate here. I know this was very, very quickly, but we wanted to make sure we have enough time for questions. And you'll find these slides in your booklet that I know that MCCPOP leadership will disseminate, and I'm happy to take any questions, and I'm sure Susan is as well.
Absolutely incredible, both of you. Just great presentations. It's incredibly interesting. One question, in fetal surgery, how do you sedate, or what's the best way to sedate the fetus?
Yeah, it's a great question. So it really depends on what the anomaly is and what the approach is. So oftentimes, for example, if you think about fetal ludo, where we know there's no amniotic fluid, there's not a lot of movement there, so we don't need to sedate the fetus. When we perform open fetal surgery, not only do we sedate the fetus for spina bifida, but we actually have pediatric ENT there to provide not only sedation, but actually pain medication that the fetuses have, and additional medications to decrease the incidence of bradycardia. So it's anything from nothing all the way to sedation, pain therapy, and resuscitation, depending on how involved the therapy is.
Pediatric anesthesia, I think you said.
Oh, sorry, not ENT. Yeah, pediatric anesthesia.
But,
I was just about to say.
Neonatology is also in the room during the entire fetal intervention as well. So there's a huge amount of pediatric fetal support for that. And mom is under general as well. So,
right. Shout out to pediatric anesthesiology.
And to OB anesthesiology too.
Love you. How often do you need to do an exit procedure?
Yeah, you know, it's interesting. So I think we're pretty judicious, and Susan, you please chime in as well. But from my perspective, I think we're pretty judicious about the use of that. I mean, we recognize that it's not a benign condition or procedure. We know that mom is under, not only is it a surgery, but mom is actually under general and does not experience the birth. And I think it's the most extreme. We use it as a tool in the most extreme cases. And then we have some other things that we can do, not an exit, but maybe not a regular delivery. So we can do side-by-side deliveries. We can optimize the location of the delivery. There are a lot of things that we can do. We reserve that for the most severe cases. We perform multidisciplinary consultations, looking at the airway and other things with MRI. And so I would say we do it a handful of times a year. And I think we're pretty good about judging who really needs it. And Susan,
I agree. I think the primary driving cases are really ENT cases. And as Yair said, we review those cases multiple times. It is a huge big deal, especially for the airway cases, because we have, as you can imagine, a multidisciplinary team that must be there in the delivery room. And so we kind of need to have this specialized team, including neonatology, ENT, OB, and pediatric anesthesia, and more broadly, you know, and general surgery, all sort of on call all the time in case she goes into labor. What Yair alluded to as well was we have developed some unique complex delivery approaches that that obviate or ameliorate the need for exit for instance, fetal lung masses. And as Yair was alluding to, we have some complex cesarean section deliveries that we plan for in the main operating room, with another operating room that is ready to go for immediate neonatal surgery for some of the larger lung masses, rather than an approach that has been taken in the past, which is kind of utilizing exit to potentially do surgery right on the mother's abdomen, which, you know, fortunately we've not needed to do that.
I just keep hearing, like, we're thinking about the word coordination. This just shouts out coordination. One last question before we go on to our next, we have a panel. Are there any new techniques for innular treatment of congenital diaphragmatic hernia?
Yeah, it's a great question and very timely. We're all eagerly awaiting the results of something called the TOTAL trial, which is a mostly European study. We just found out that it's going to be presented at the next ISPD, International Society for Prenatal Diagnosis, which we're very much involved with on the organizational front. So that's going to be presented in about a month or so. We've been developing a program here at Packard over the last 6 to 12 months, where we think that we now have the appropriate pieces between MFM, neonatology, ENT, and others, that we anticipate the results will show a benefit in a subset of patients. It's unclear which subset, but that's our hypothesis. And we're going to be, and we are now almost ready to launch a program as soon as the data supports that kind of intervention. Another important component that Susan will expand about in 30 seconds, I'm sure, is the ECMO program. So irrespective of therapy, what we've seen in our own data, and we have ongoing analysis of our own data, both locally and nationally, is that survival is one thing, but morbidity is another. And you really need to have a robust and significant ECMO program to treat these cases, and especially longer term when you talk about pulmonary hyperplasia and hypertension and other things. So we really think we're very, very well positioned to launch this here, but we're all eagerly awaiting these data. So a great timely question. And Susan, I don't know what
I will just say, Christina, to harken back to your coordination issue, I think what you're hearing from both of us is that, again, it's really the clinical arc of care. If we don't have in an institution a profoundly outstanding neonatal ECMO program and pulmonary hypertension team and pulmonology group, we really can't launch something like a new program that would focus on fetal intervention for congenital diaphragmatic hernia, which, as Dr. Blumenfeld said, I think we really are in a unique position because we do have those components. But I also saw in the chat another question about renal transplant. And to harken back to Yair's discussion about the RAFT trial, we are really fortunate that we have an extraordinary renal transplant and renal dialysis team at Stanford, which has really allowed us to participate in the RAFT trial and actually have cases referred to us from other groups that really understand the importance of that continuum of care. In our renal transplant team's hands, if a neonate gets on the path toward transplant, meaning they have started dialysis, et cetera, they've quoted a 70 to 80% survival to transplant rate at Stanford. So it's really important. I guess I'll just end on that, to have the view that fetal therapy and fetal care is really a continuum, and that complete continual arc of care needs to be really strong.
We're ending on that. Everybody stay tuned. We have an incredible COVID panel. These folks are all in the thick of it, let me tell you. Yair, Susan, you guys both rock. Love you. Have a fabulous afternoon. It was a great presentation.
Thanks for inviting us.
Thank you.